Okay, we are super excited today to have Dr. Jenny Bepple here. Jenny is a urologist who seems to be seemingly everywhere these days in terms of everything to do with digital health and value-based care. And Reza and I both met Jenny independently, and everybody considers you like not only an amazing clinician, but really an amazing person in the digital health space. So welcome.
Thank you so much. I love the fact that I met you each independently, and we've been able to come together today. So thanks for having me.
Thanks, Jenny. So Jenny, how about you start us off with like a brief overview of your career trajectory?
Sure. So I did my undergraduate at Penn State, and then I went to Eastern Virginia Medical School, did medical school and residency there in urology, joined a private practice in Maryland right out of my residency, worked there for a number of years, and then we were acquired by a PE firm. Um, you know, really liked solving problems, liked not doing the same thing exactly every day. So, kind of sought after that. So that had me, make a couple of other jumps within the practice, became the director for digital health for a large PE back group, went back, got my master's in management of clinical informatics at Duke, and now serve as a fractional CMO and CMIO to digital health companies.
Wow. When we met, you were an amazing urologist here in Columbia, Maryland. So walk me through that initial PE acquisition. What were the discussions pre, post, from a clinical perspective? What were the leaders of the group saying? How did it pan out?
So, our group was small, 6, 7 people, and there always seemed to be something, right? Like that next large expense that really kept you from growing as a practice. And the IT costs were growing. It was becoming, challenging to recruit into the smaller practice that maybe couldn't offer all the ancillaries as far as the larger group. And so this was going to be, we looked at different options. We looked at being hospital owned. We looked at doing this, and this was going to allow us to continue to have urology leadership within, the PE organization. So, at that time, it was kind of the next best step for us.
So PE roll-ups get some bad press recently in various things and Freakonomics and whatever else you listen to these days. Tell me like what happened afterwards. Like you were still there for a few more years, right?
Yes. So I think that afterwards you kind of go through your Cinderella period. Um, you know, there are challenges, right? So you do have urology leadership, but you're also answering to another layer of financial sort of responsibilities. And so that becomes challenging, and really just being able to translate what you need to get done clinically into the world of, where you're counting everything, right? Like you're counting every roll of toilet paper that goes out the door, and so you're defending each of those parts to it. But it also provided opportunity for me during that transition. I was mentioning that I like to solve problems in the practice, and I had done that. I had built out an in-office dispensary when we were a small practice, and that was very successful. I think it helped patients access their oral oncolytics for prostate cancer, treat ED and things. And so, really, I professionally and personally was challenged by access to care. So, personally, I had 3 young kids. I was traveling long distances to get them care. Actually, where we decided to live was based upon the healthcare of my kids. And then professionally, as a female urologist, like there aren't a lot of us, right? So women would travel really long distances. And it just felt wrong. Like it didn't seem like someone should have to take off a half day of work to come in to get a refilled prescription and such. So I sort of decided to put on all the hats and look into like what was telehealth like in Maryland. This was in 2017. So that's when I attended my first American Telemedicine Association meeting and decided like, look, we needed to do this. But we had just joined this PE group. I had an amazing executive sponsor who really believed in this and had already written sort of an internal white paper for the group. But pitching telehealth in 2017 to a surgical subspecialty was like a screen door on a submarine. And so that took a lot, right? Like that was knocking on a lot of doors and banging on doors.
So what were you pitching at that time? Was it like a fee for service model or something else for telehealth?
No, so fee for service model. Maryland had coverage parity laws, and so I just wanted to do a pilot. Like, could we get paid by insurers? I didn't want patients to have to pay extra and kind of do all those things. So I think they got tired of me. And in 2019, they said, fine, Jenny, go do a pilot. Like, how much could it possibly cost us?
Yeah. So how did that go? Tell me.
Yeah. So I got two other partners to join me in it because I didn't want to be the only person saying like this is successful. The physicians thought it was really successful. It was incredibly efficient, ran on time. And the patients loved it. I mean, they had, easy access to care. And yeah, it was easy that way. And so high satisfaction. We had some technology challenges that I'll say, like, it, you know, we knew that we had to go shopping sort of for a technology platform. But we went into 2020, January of 2020 had, as a company, I led our first digital health summit and said, look, this is what's going to happen. This wave is coming. You can either be sitting on the beach watching it. You could be like crashed by it, right? Like there's men's health companies popping up all over digitally. And if you think that they're not taking your patients, you're wrong. Or you can try and ride the wave, right? Like learn how to surf. And so that's what I pitched. Was like, how do we learn how to surf?
What
It's
great
amazing.
timing. I mean,
Yeah, it kind of
Right. So
it,
so better to be lucky than good sometimes.
it parallels a little bit my experience. I was in the ED group. We sold to private equity in 2017 as well. But before that, around 2014-ish, my boss came to me and he said, Alex, we know how to make money by getting patients into the ED. I need you to figure out how we can make money by keeping patients out. And obviously, the only way to do that is with telemedicine, and that put us on that whole trajectory. And I led the creation of our telemedicine program. So kind of a very analogous story to solving an internal problem, building some expertise, and then taking that expertise elsewhere, right? Because it sounds like you then took that expertise and you eventually left that group.
Yeah. Right.
Yeah. So tell us, so what happened then? When did you leave, and then what did you do next?
Yeah, and Alex, I'll tell you too, the other way that parallels is the fact that I'm sure when you were like, look, as an ED physician, I'm going to try and prevent you to not see me, right? And they went, what?
Yeah,
Like
the
we
payers
make
don't
money
believe
by
it.
seeing patients.
Yeah.
Right, exactly. And so, it's an interesting journey as a physician, like, medically what the right thing to do is. And I think that learning how do you translate that into the finances of our healthcare system is it's an important distinction, especially when you're trying to pitch to executives and understanding sort of your stakeholder and what their incentives are, and saying, hey, look, true healthcare, keeping people healthy can be profitable too. So how that transitioned for me, well, COVID hit. So suddenly this tiny little telehealth program that not many people knew about. I will say the executives were behind it after the Digital Health Summit. They wanted to learn how to surf. We were going to go shopping at Hims for a technology platform. And then we couldn't go because that was March of 2020. And yeah, so it went nationwide and in that tragedy was again also opportunity. So I became the director for digital health and suddenly was splitting my time sort of 50-50 between the clinical and the administrative side. And it was go time. I mean, everyone was open to it. Everyone wanted to learn how to do it. How do I offer this to patients? How do I do it well as a urologist, right? Like what can I see and what can't I see or shouldn't I see on telehealth? So there was a lot of teaching there.
Well, tell us some examples of that. I mean, inquiring minds want to know, how do you go about like telling people, it's time to now see what we need to see.
Some of it takes humor. I remember one of my docs told a story about how, he was joking with his patient. He's like, okay, it's time for your prostate exam. And the patient starts to stand up. um, so,
Oh my gosh.
there's a lot of that. There's, a lot of like, but there are some things, right? Like this is what a patient wants to show you. And I can see that fine. Some of it though is also, right, it's teaching the privacy of, when we're discussing your erectile dysfunction or, your dyspareunia, you may want to close the door because your kids are right there.
Oh, wow.
Or yeah, and it's the same thing as like when you go into the OR and you're trying to go over, what's your surgery going to be like, and how do you ensure privacy for your patient and each of those parts to it. So patients were excited, but I'll tell you the one thing I learned, like I was kind of naive going into COVID, because I really thought I was like, everyone's just going to want to do this. Like, why would you not want to like do this from a patient perspective, from, the physician perspective? And I was really naive that CMS was going to move on this quickly. In retrospect, CMS would not have moved on this quickly. Practices would not have like adopted it. And therefore patients would have been slow to pick it up. It would have sort of stayed in the DTC and pay out of pocket model, which was not what I wanted to do. So that was definitely a learning and how to, all of those pieces could come together. And so I saw this as not that I had a blank check into digital health, but I definitely saw it as, hey, look, there's more we can do here. I got super interested in the data and understanding the patient journey and why were we losing patients? We would have women who would really get advanced, diagnostics for their incontinence and then wouldn't have it like surgically treated. And what happened to them? Why did that happen? Or prostate cancer care, like they were getting these oral oncolytics and now they aren't. Like where did they go? Where are we, kind of losing patients in that journey? And I thought that data held a key, and understanding, right, in that data, information, knowledge, wisdom sort of a triangle is that we just had a ton of data and had no idea what to do with it. And so I wanted to build on that. I loved being the bridge between the patient and the physicians and the technology. I thoroughly enjoyed getting to work with our, technology and systems folks. And they were super bright, wanted to do the right thing, and kind of needed a little bit of like a, physician guidance as far as, hey, what are some of the things that we need? And I needed their guidance to tell me, here are some of the ways that we could fix that. So it became a wonderful partnership. But kind of to the launch in that, seeing the opportunities in data, really kind of feeling like my career had been invigorated by getting to build, and understanding myself more and knowing that is something that I really enjoyed in a career. I was looking, like I kept trying to build these things, and I had learned how to become an entrepreneur, and I wanted to take it a step further. So that's when I went back and I got my master's.
I always joke with Alex that he always loves to be a builder and tinker, and some of the things he's building at times, and all of us, we're too expensive of a resource to be the primary person building it. So walk me through this balance between, I'm excited, I'm interested, I want to solve this thing, but I'm a physician leader, and like the best thing for that entity is to do this at fourth of the cost of that I'm bringing to the table in the short term, but in the long run, they've built it better, right? Like walk me through a couple examples of how you've navigated that.
Yeah. So, you know, being board certified in informatics and having the master's, people will say like, "Oh, so are you coding for these companies?" And I look at you and say like, "No, like if I'm coding for you, we've got bigger problems." To your point, because I'm an expensive resource, and not only am I expensive, there are people who can do this better. And so it's really identifying like, what are you good at? And where do you need a partner? And that was the same thing with my experience, in the group is that, look, I knew that I needed partners in technology to build something better. And so, yeah, I mean, each part of that, and we build out models to re-engage patients, and that required a partnership, right? Understanding the systems. How do you find the patients? How do you do outreach with those patients? And it's definitely not me doing each of those parts to it, but it's me sort of pushing into where the clinical questions and understanding the workflow.
Tell us a little bit more about what you're doing now.
Sure. So I serve as a CMO and CMIO in fractional roles to these digital health startups, and this is a great example of, again, an expensive resource, which is why most of them have you as a fractional role. And but you do wear more than just like a medical hat. So I typically tell physicians when they're trying to figure out what they do is that whenever you were trained to be an ER doc, be an internist, be a urologist, you weren't trained just to do that, right? You were trained to think critically and with compassion, and you can use that in a lot of different areas. And so I think it's with that sort of lens that you can go and you can build these digital health technologies. So I've worked, both in building out models and virtual specialty clinics and virtual care, as well as in technologies that are patient facing and practice facing, and adding operational efficiencies there. And so there are parts of that like physicians know, deeply. I know that a physician is going to like a product or not like a product, and what are their barriers going to be to using it. Did you make them click more? No, right? um, and even if you make them click the same, then no, right? Let me click less.
I want to make a point here because you said something really interesting, Jenny, earlier on. You said that you love being the bridge between the patients and the providers and the tech. And, Reza and I'm sure you as well, we get to engage with many different sort of physicians in some sort of fractional advisor or CMO role. And I feel like I've noticed there's two tiers of these sort of clinician advisors and CMOs. Tier one is, then the lower tier is, you're a domain expert in some clinical field, and you're bringing really good clinical expertise and insights, like what you just mentioned about, change management, how much is it going to cause them to click and all that. But the really higher level, and what you've done and what Rez and I have done, is where you can actually not just bring the domain expertise, but act as the bridge where you understand the language, the terminology, and the perspective from the data side, from the business side, right, from the marketing side, and you can actually act in those from those perspectives. You can create insights and make progress in ways that they couldn't be able to do that by themselves. And I think that's really what we're hoping to help folks reach, is like, if you can really learn these other domains and their language and their perspectives, then the value you can bring is so much higher.
1,000%. So, as the SME or the individual contributor, you're sort of time limited, I think, in your value to companies. When you take it to that next level, and it takes time. It takes a lot of time understanding those. Agree that you have to know the terminology. I mean, when you go in, you have to understand the business side, the investing side. How's the marketing person on your team going to think? What's their sort of perspective? How do you contribute to product and things? And how do you, leverage your network to help, again, kind of lift up the company. But yes, there's definitely a different level to that.
I feel like go back to when I was a fellow, doing general medicine consults. It's like the thing that you got consulted for, and then all the other things that they didn't ask you about, and you're like, ooh, this patient's blood sugar is like 400 or something else, right? So when you work with some of these smaller startups, you get asked to like, well, help us with this, and then you're there, you're like, ooh, like you also need this and this and this and this, and so on. If you had to go back to kind of like talk to your purely clinical self back at Howard County General or wherever else you also practice, um, what would you tell yourself? Like, what if you wanted to do this sooner or better or differently in some capacity? What would you tell yourself?
You know, I don't know if I could have done it sooner. I do think that, right, like I went to my society meeting, I hung out with urologists, right? And I was definitely guilty of sort of going to work with blinders on. And so my world had gotten really small. And recognizing that there was an opportunity there to even just within my community expand beyond that, and recognize that maybe physicians that aren't, urologists were having the same challenges, and how were they like solving those and things. So I would have, in residency, your world is bigger. Your friends sort of with other specialists, and you're kind of hanging out in the hospital. You don't hang out in the hospital anymore. You run in, you do your consult, a PA is there to help you. You run into operate, and you like run back to your clinic and things. And so I think that I would have, told myself to keep my world a little bit more expanded. So to Alex's point, like you can learn those other parts to the hospital, those other parts to the business, because there's so much. I mean, all this stuff has been taught to me by people who have been very generous with their time, so that it allows us to now be, the Swiss Army knife on a team.
So Jenny, I'm sure you get approached quite a bit by various digital health companies, given your kind of stature in this domain. So what are some of the red flags that when a company engages you, or it might not be a red flag, but it's some sort of indicator that it might not be worth your time?
So I'm going to take it to the positive and say, like, how do I tell you that it is worth
That's
my
too
time?
nice.
Okay.
And say, like, I've narrowed it down to really, two categories. One, do I care about the problem that you're trying to solve? It's not worth your time. And you have to feel for it, right? So that you're thinking about in the shower, and again, trying to be creative and think outside of the box. So do you have a legitimate problem in healthcare? And is it something that I can invest my time in it? Do I care about it? And number two, do I get to work with awesome people? The team is critically important. And so, and even like within my network, I always tell people, like, look, I only hang out with awesome people. So if I'm going to introduce you to someone, I can guarantee you that they're going to be awesome, because that's, those are the people who have been generous with their time and are supportive of other people's endeavors, like both of you, that really kind of makes it all worthwhile.
Should we change our LinkedIn tags that we only hang out with
Yes.
awesome people? Is that
Yes.
the
Or
next
you can
move?
just put on there like awesome person. Like,
I want to add a third bullet to think like that lately has become a huge one for me, is, and I'd love your perspective on this, Jenny, is how easy or hard is this going to be to actually commercialize? Because it might be a problem, like it might be an actual problem, but the sales cycle might be so painful, or the business model that the company is proposing is not the right business model. So because of that, it might fail, even if they're awesome people. So talk to me about that.
I mean, you're right. So it could be that their approach is sort of wrong. I don't say no to that opportunity, depending upon if the team is open to listening to you saying. I am very open with, like, I think
Yeah.
your approach is missing the mark here a little bit. Here's why I think that. And if they are, level set on, nope, this is the direction we're going in, and I say, like, I wish you the best of luck. Like, I just don't think I'm the right person for this. And it's not that I'm always right or anything like that, by any means, but there's some experience that sort of gives you an idea that you say, I can't get behind this. So, but that's part of, that team is the team sort of in a position that they're open to those types of suggestions and feedback.
I like it. I like it. I go back to like when we were clinical and our team was other clinical folks, whether additional doctors or hospitalists or nurses and so on. And then now our teams are mostly multidisciplinary, and you might be the only doc on the team doing a variety of things that you're doing, we're all doing. How do you think that transition happened in your mind of going from the docs always know what's right to now I need to advocate for finance or the man, and being comfortable with that in your authentic self?
So when I was in college, I had a health economics professor who said, no margin, no mission. And so that's what I keep in my mind, right? Like a business has to be financially healthy and profitable in order to get the mission done. And so, if I am advocating kind of for the man, I will say that as a CMO, like my number one role is, a consummate advocate for patients and physicians. So that's like the baseline for all of us, I'm sure. And the Hippocratic Oath. And then beyond that, though, like it does have to be financially reasonable.
I think that part, the first part of advocating for patients, comes very easily to all our listeners, right? They've devoted 30 years of their lives to this, from when they were 6 years old, right? It's the other piece that sometimes feels foreign to them, and getting comfortable with the idea of you now represent the margin. Like,
Um, how do you do it and not feel like you have sold out to the man, so to speak? Yeah, I mean, you're right. There definitely is a point in being comfortable with that, and I think that that's why when I look at it, I like to be able to show, like if I have a slide like ROI, there's also the ROH. So there's like what's the return on health and what's my return on investment, and they're equal, right? Like you have to have a return on health. Um, but you won't get anything done if you can't also show the ROI with it. And some of it too is a lot of physicians, to Alex's earlier point, like we weren't trained on any of this. Like we don't know how the cheese is made. We don't even know how much money like the practices are bringing in, or how much, whatever E&M code is that we build, or why they're watching like a certain procedure getting done, and the revenue associated with that. But all those things keep the lights on and keep patients being able to be safe and be taken care of.
So Jenny, one of the big topics for our students is, well, how do I actually get some sort of gig, right? Whether it's a fractional thing or a full-time gig. So in my mind, the two big buckets of sources that I've been able to get my gigs are, one, by saying yes to all sorts of projects early on in my career, and just taking the lead on it, and two, kind of through my network of friends and relationships and connections that I've built over time, right, and nurtured over time. And then there's a third bucket, which is everything else, right, where you might just apply to something or whatever. So I'm curious, from these three buckets, like where have most of your opportunities come from, and what's your approach to all this?
Yeah, I mean, almost all of them have come from that second bucket. There's definitely been this, from that second bucket in the beginning, like trying to say yes to everything. And then you're a little bit more strategic in your yes to, in the beginning, you're saying yes to everything mainly because I just wanted to soak up everything I could learn. So it's not, the financially why you're saying yes. You're like, I'm going to say yes to this because I think I can learn X, right?
Yeah.
But when I was getting my master's, I was applying to a bunch of things and I didn't know where I would end up. I just
Right.
assumed like I'd get some full-time role, I don't know, payer, pharma, what have you. I didn't get interviews. Like it didn't really go anywhere. And I was shocked because I'm like, doesn't it, you come from a world of clinical practice where everybody wants you, right? Like, aren't you in high demand? But we are, we are expensive resources. And so really it was from networking. The first advisory role I got, and I'm still working in today, is in real world evidence. And it was because I had met with someone who had completed the same master's I did, and she was working at the FDA, and she introduced me. She was like, "Oh, you should meet, um, my husband, who's CMO over here." And it wasn't even to get a gig; it was just, expanding my network and being open to the learning process. And everything kind of since then has been, I've met someone, and then someone said, "Hey, I know somebody who could do that." So, yeah, the network.
And I think about that network as you start off with serendipity and saying yes, but very quickly soon after, if you drive value for all of those smaller gigs, then people are actually referring you as opposed to doing you a favor, right? That transition is very important. That people say, well, Reza, 20,000 people, like, can you, refer me into this? I'm like, well, you haven't done anything yet, right? Like, so
Right.
maybe like increasing that surface area of luck in the very beginning, but very soon after a couple of years of good work, it becomes much easier for everybody else to refer you places, because you deserve it.
Right. And I think that physicians have to learn too is, how do you, right, you know how to do quality in your specialty. Like if I put the boxes, I do my guidelines and things like that. But driving value to a company is beyond like putting boxes in the guidelines and doing those checklists. So how did you play that role in that company?
That is brilliant. That is so brilliant. So Jenny, what does the next 5 to 7 years look like for you in your mind, and what are you most excited about?
Yeah, I'm excited to keep building. I again, I like I said, I realize that that is something that I really enjoy and want in a career. So I'm excited to continue building with awesome people. I think that, we're not even at the tip of the iceberg as far as what's going to be coming with AI and machine learning and all the different parts that it's going to touch a practice, and a physician and a patient. And I think that as physicians, like we are in the best position to continue advocating for, our patients and our profession, to make sure that we're building the right tools.
Well, congrats on all that you've done so far, and we're super excited to see what amazing things you're going to achieve in the next few years. With that, I guess, any final words, Alex?
No, but Jenny, any final words for this the studio audience who's so eager and hungry?
No, I just want to thank you both for your support in my career and for your friendship kind of through these years too. And again, to the other physicians who are out there trying to do the same thing, is believe in yourself, take some risks. You're willing to invest in so many things, and it's worth it to invest in yourself and what you believe in.
Awesome. Thank you, Jenny Bepple. Thank you so much.
Thanks.